Hi, I'm Siobhan, a senior medical resident at McMaster University. In this video, we'll be going through a practical approach to the diagnosis and management of COPD exacerbations. This video is intended for subspecialty physicians who are returning to general internal medicine during this COVID-19 pandemic. So just remember that you're never alone managing these patients and that there's always physicians you can call at home or in the hospital for additional assistance. COPD exacerbations are characterized by acutely worsening respiratory symptoms that then require additional therapy. So some common triggers are viral or bacterial infections, environmental triggers like smoking or allergens, and medication non-adherence. It's also important to think about other causes of shortness of breath. That would include myocardial infarction, congestive heart failure, a pneumothorax, or aspiration. Your initial investigations are going to be aimed at ruling out other diagnoses, determining the trigger for the exacerbation, and figuring out the severity of this COPD exacerbation. So we'll start out with a basic panel of blood work, including a CBC, electrolytes, troponin, creatinine, and blood gas. Pay special attention to the rise in the CO2 and whether the patient is acidotic. Then get a chest x-ray looking for volume overload, an infiltrate, or even a pneumothorax. Get an ECG to look for signs of ischemia or arrhythmias. And then think about infections, so nasopharyngeal swabs for viruses, sputum culture for any bacteria, and then consider blood cultures if you're suspecting sepsis. In the back of your mind, always keep that diagnosis of a pulmonary embolism and look for clinical features like an active DVT, unexplained tachycardia, chest pain that's pleuritic, or hemoptysis, especially in patients with active cancer, recent surgery, or immobilization. All right, on to the acute management. So there are 5 general principles I'd like you to keep in mind: supplemental oxygen, puffers, steroids, antibiotics, and considering whether the patient requires ventilatory support. Starting with oxygen, you want to titrate your oxygen saturation to 88 to 92%. That's to prevent hypercapnia, and it's especially important in those patients that have a CO2 level that's elevated at baseline. Then you want to add puffers. So start with your short-acting puffers, Ventolin and Atrovent. Both of them are prescribed the same way, 2 to 4 puffs every 4 hours scheduled, and add on a PRN of Ventolin, 1 to 2 puffs every 1 hour as needed. Now, if the patient came in already on long-acting bronchodilators, continue those puffers in addition to the short-acting ones. Steroids should be given by mouth rather than the IV if the patient can take oral medications. So a common prescription would be 40 milligrams of prednisone times 5 days. Antibiotics should be considered for all patients even if they don't have a consolidation on the x-ray, if they meet the following criteria. So you need 2 out of 3 of the following: shortness of breath, sputum purulence, and increased quantity of sputum. The question is, what antibiotic? So you can choose either a respiratory fluoroquinolone like levofloxacin or moxifloxacin, or another good option is a beta-lactam beta-lactamase inhibitor like amoxicillin clavulan. If the patient looks quite ill, looks to be septic, or has a clear pneumonia, then consider using a beta-lactam plus a macrolide like ceftriaxone and azithromycin. Ventilation. So who would benefit from non-invasive ventilation like BiPAP? Patients who have severe dyspnea, who have increased work of breathing, whose blood gases show a pH less than 7.35, and their CO2 is over 45. But I want to caution you, during this COVID pandemic, if someone has a suspicion for COVID-19, we do not recommend using BiPAP. That's because blowing of the air can spread and aerosolize the virus. So if you're having this discussion, should this patient benefit from BiPAP, call the respiratory therapist, discuss it with the ICU attending that's on call to make that decision together and weigh out the risks and the benefits. If you are using BiPAP, then remember the contraindications. If a patient has decreased level of consciousness, if they can't clear their own secretions, if they got facial trauma, respiratory arrest, or significant hemodynamic instability. If they don't qualify for BiPAP, or if they try and fail at BiPAP, then call the intensive care unit and consider the need for intubation. So in summary, when treating a COPD exacerbation, consider oxygen, puffers, steroids, antibiotics, and whether or not the patient needs ventilation. If you want to learn more about COPD and COPD exacerbations, then see the links below. You can find a link to the chapter on COPD in the McMaster textbook, as well as an infographic made by the internist at work. I'd like to really thank those who collaborated on this project, including intensivist Dr. Jaeschke and respirologist Dr. Joshua Wald.